My talk is on hook of hamate stress fractures in cricket batters, which is one of very unusual and a rare injury in cricket. Just a background, I did my residency in sports medicine and I work at the Center for Arthroscopy and Sports Medicine at the BLK Max Hospital in Delhi. So mine is a case series with four athletes with a mean age of 22 years. All of them are male and the injury happens in the non-dominant hand. The average time from symptom onset to diagnosis is around 4 months. Just a brief review of the anatomy. So hamate is the most ulnar bone in the distal carpal row, which has a hook which acts as a pulley for the fourth and fifth flexor tendons. The hook also forms the lateral wall of the Guyon's canal from where the ulnar nerve passes. The mechanism of this injury is pretty straightforward. The non-dominant hand, the hamate abuts against the cricket bat and repeated trauma leads to bone marrow edema and eventually a stress fracture. The athlete usually comes to you with ulnar sided wrist pain, difficulty in gripping, and sometimes a weak grip. If the ulnar nerve is involved, the athlete may have some sensory or motor symptoms in the ulnar nerve distribution. In terms of investigations, standard AP and lateral view X-rays don't do justice to this X-ray. What you would require is a carpal tunnel view, which may show the fracture line in some, but not all cases. The investigation of choice is a CT scan, but I prefer doing an MRI because it helps me look at the other causes of ulnar sided wrist pain. Starting with my first case is a 23-year-old male left-hand bat plays semi-elite cricket, presents with right wrist pain and difficulty in gripping. We do the MRI. The first is a corneal section, shows extensive edema in the hamate. On the sagittal sections, we can see an incomplete dark linear fracture line. The radiologist could see some perineural ulnar nerve fat stripping without any signals inside the ulnar nerve per se. We immobilized the athlete for 4 weeks. He started training when he was non-tender on palpation. Return to play was around 4 months. At 2-year follow-up, the player is pain-free, playing at the same level and refused any further imaging. Coming to the second player, 20-year-old male right-hand bat, problem in the left wrist. We do an MRI. There is some mild marrow edema on the corneal PDFS sections. There is some negative ulnar variance, which is not that relevant. The ECU groove on the ulna is shallow, and you can see a fracture line on the axial T1 sections. Manage this player again conservatively with 4 weeks of immobilization. This is the MRI 2 years of follow-up. So although the fracture line is still visible, the player is actually pain-free and playing cricket at the same level. So probably I would classify this as a asymptomatic non-union of the hook of hamate. Just to compare the previous X-ray and the 2-year follow-up, if you look at the arrows, the fracture line is pretty much the same, but the athlete is actually pain-free at 2-year follow-up. The third player is a 22-year-old male right-hand bat. Again, problem in the left hand. The MRI shows a clear fracture in the axial T1 sections. There is some marrow edema and there are some other ganglion cysts, and that's why the importance of MRI in such players. We follow the same management, but this time we fail. The athlete fails conservative management. It's painful at 3 months. The decision was taken to excise the bone, the hook of hamate. So the first image, you can see a fracture line at the hook of hamate. Was referred to a hand surgeon. Daycare surgery was performed. The athlete was released the same day. Wound care was done for the first 2 weeks, starts training at 3 weeks, and returned to play in just 8 weeks. Player number 4 is a 23-year-old male right-hand bat. Again, comes with left wrist pain, same problems. Doesn't have any ulnar or sensory or motor symptoms. Do an MRI. There's a clear-cut fracture line seen on the axial T1 sections. Discussion was done based for conservative and surgical management. The athlete opts for conservative. COVID strikes, comes to us after 1 year. This time he has the same problem, also has ulnar nerve symptoms. So we repeat the MRI, the fracture line is still there. There is no evidence of fracture union. There is no bone marrow edema. So probably a case of symptomatic non-union of the hook of Hamate. Excise the hook, the athlete comes back to play in 10 weeks time. There are no ulnar symptoms at 6 months follow-up. At 2 years, the athlete is pain-free. There is no features of ulnar neuritis. The athlete is playing professional cricket. So when we look back on our conservative management, half of our athletes did not require surgery. All of them were pain-free at 2 years. Player one was probably uncomplicated healing, but we cannot say because the athlete refused any follow-up imaging. The athlete two still had the fracture line at 2 years, so probably a case of asymptomatic non-union of the hook of Hamate. The only problem with the conservative management was the longer rehabilitation period for about 3 to 4 months and 50% chances of failure as per our experience. When we look at the literature, so conservatively managed hook of Hamate fractures are rare, with only one, to my best knowledge, and I might be wrong, there's only one study which sees the hook of Hamate stress fractures is done by the organizer, Dhillon sir, and they manage the player conservatively with return to play. Surgical management is actually very straightforward. You just do a excision of the hook under JK surgery. You care for the wound, rehabilitate, and the player usually comes back in about 8 weeks. There is a shorter return to play timeline. It is a definitive management, and outcomes have been proved in other racket and bat sports, but not in cricket. Again, if we look at the literature, the study by Mittal, they did a comprehensive literature review. 111 players, they did the excision, and only 7 were managed conservatively. Out of those 7, 3 again required surgery. The latest research which I saw was progression of Hamate stress reactions in elite baseball players. Baseball, a sport similar to cricket, but I'll not say is the exact same mechanism of how it works on the Hamate. So they had 4 players. They did the MRI. Initial MRI had bone edema, but no fracture line. They managed all of them conservatively. All the players returned to play, but within an average of 4 weeks, all of them acutely fractured their hook of Hamate. The hook of Hamate was excised in all 4 cases, and all of them returned back to their previous level of play in 5.3 weeks. So, as per this paper, the author said if there is no fracture line, let the player play. Do not do any conservative management. Let the bone fracture. Once it fractures, you remove the fracture fragment, and the athlete comes back to play. So surgical candidates, in my opinion, are those who, number one, fail conservative management. Surgery can be the first choice of management if there is a symptomatically displaced fracture, if there are ulnar nerve symptoms, and in cases of elite players. Because the timeline for conservative management is around 3 to 4 months. If the athlete fails, then add another couple of months, so the athlete is out for 6 months. Whereas surgery, the literature says the athlete comes back to play in 6 to 8 weeks. Conclusion, batters with insidious onset of pain in the non-dominant hand should raise the suspicion of hook of Hamate stress injury. Incomplete fractures may be given a conservative trial, whereas surgery leads to earlier return to play.